Chapter 13, Video 3. Now we're going to talk about bundle branch blocks, okay? With the bundle branch block, we have a block in the right or the left bundle branch. The impulses travels through the healthy bundle branch through one ventricle, and it goes slowly, cell by cell, on the affected side. So we see that with the bundle branch block. And they're seen often with patients who have supraventricular rhythms. Ventricular rhythms cannot exhibit bundle branch blocks, and the results are equal a widened QRS with characteristics in the QRS shape. So it's going to be greater than 0.12 seconds. And I think that'll make sense to you again as we move forward. We're going to talk about the normal anatomy, the bundle branch blocks with the normal anatomy of the bundle branch system. The right bundle branch is located on the right side of the interventricular septum, with the left bundle branch be on the left side of the septum. So with the left bundle branch, it has two divisions or branches that are called fascicles. So when we talk about that, let's go right here and look. So we have our AV node, and then we can see that we have the right bundle branch, and then we can see here that we have the left side, and this left side branches off into the posterior fascicle and the anterior fascicle. So please know your anatomy with that. Lead V1 is best to use when we're determining if we have a bundle branch block. It sits to the right, and the impulses are traveling away from the positive electrode wire, which show a negative deflection. So V1 is primarily negative, okay? So with the bundle branch blocks, these bundle branch blocks happen. They can happen when either the right or the left side becomes blocked. So something happens along this pathway, and it blocks that electricity from traveling down. The electricity travels fast down healthy tissue and slowly down, it trudges slowly down affected tissue. So tissue that's not so healthy, it can travel slowly down that tissue. The difference in the impulse can cause ventricles to fire consecutively instead of simultaneously, and it can cause a wide QRS. Okay. So what may happen is remember when the heart beats, the top two atrium squeeze together and the bottom two ventricles squeeze together. So if we get a block here, the right ventricle may squeeze at a different time the left ventricle squeezes. So we may lose sync in that rhythm there. So this is normal conduction for lead V1. So this is what you should see in lead V1 with normal conduction. With a right bundle branch block, we're going to break these down into right and left. With the right bundle branch block, which is known as RBBB, the QRS complex typically starts out looking normal, but then you may see an extra R wave that signifies that the current is trudging and traveling slowly, okay? You're going to see the QRS that's greater than or equal to 0.12 seconds. You're going to see this with an RSR configuration. What we mean by that is you're going to see an R wave. So when you have the QRST, you're going to see QRSR. You'll have another R tossed in there. And that R signifies that that current is traveling really slow. The T wave slopes opposite. It slopes to the opposite of the QRS. So let's take a peek at the next slide. And this will show you that RSR. You have the QRS, so you see that RSR, and then your T, so QRST. But you see that that RSR configuration. This is what we're talking about here. And then when we look on past it, that T wave dips down. It's opposite of the QRS complex. So that's not what we normally see. So this is indicative of a right bundle branch block. When you see that RSR and when you see that T wave dipping in that opposite deflection. So looking at an entire strip here, and we know with the bundle branch blocks, we're going to go where? To V1. So we see that it's all right. So let's look at this. And when we're looking at V1, QRS. So we see that R, S, R. So we got the double R's here, and then the T wave is negative. T, and then we don't see that we got the P that's dipping down. P, Q, R, R. We got a small R here. S, R, and then that is going opposite. So that's the configuration that we're talking about right there with the bundle branch block. Now let's talk about the left bundle branch block. With the left bundle branch block, it can happen in two ways, okay? Block of the left common bundle branch, or it could be a block into both fascicles, because remember, the left blocks off on the left blocks off on the fascicles. I'm sorry, I'm getting tongue-tied. That left block, that left bundle branch has two fascicles that branch off of that. So we could see a block in the common branch, or we could see a block in either one of those fascicles, is what I'm trying to say. And I got a little bit tongue-tied, so I do apologize about that. So we're going to have, again, a wide QRS, 0.12 or greater. And then you're going to see that wide QS or RS configuration. And the T wave, again, slopes opposite. So let's put that criteria into spectrum here. We see the width of this QRS here is wide. And then you have that, we have a Q. All right, so we had that QS configuration, QRS, that's dipping negative and it's wide. So this just kind of shows you what that left bundle branch looks like. So looking here at V1, see we have that wide QRS complex, and then we have that elevated T. So that's what you're going to see there. Bundle branch blocks seen only at certain heart rates. Blocks that are seen at only certain heart rates are called rate-related blocks. So if you're doing an EKG on somebody and you don't see that bundle branch block, it's not there. But if something happens and that rate changes and you see that block, that's what we call that rate-related block. It's only seen at certain rates. The critical rate, when we think about the critical rate, the critical rates are defined as the rate in which the block appears. So if your heart rate's at 70 and you don't see that block, but you get up to 85 and that's when you start seeing that block, 85 would be that critical rate. That's where you're starting to see that block. So that's what we mean by that. And if you have questions, please don't hesitate to contact me. Let me know. This is a slide. It's pretty much everything that we just went over. It does add some causes here that I want you guys to look over. But know your QRS intervals here, and know this criteria when you're determining whether the patient has a block or not. This is very important. Clinical implications of a BBB bundle branch block are symptoms of an impaired conduction system. Again, R is right bundle branch block, and it can be seen in normal healthy hearts. Left, LBBB, the left bundle branch blocks, almost always implies cardiac disease. So that's very important for you guys to know. So risk for developing severe AV blocks is very common when a patient has a bundle branch block. So we need to be mindful for that. And the bundle branch blocks may cause the T wave changes that would show ischemia. So certain kinds of myocardial infarctions may be difficult to diagnose if the patient has a left bundle branch block, because it masks it. It may hide it. So if you've diagnosed this patient with a left bundle branch block and that T wave is really high, it may look like a STEMI all the time when it's a left bundle branch block, because they look that STEMI, that ST segment elevation, is there because you've diagnosed that they've got that left bundle branch block, and then 5 years down the road they have a heart attack, you might not be as quick to catch it because you think it's that left bundle branch block is what I'm trying to say. So be careful with that. So know that these bundle branch blocks with a left bundle branch block, that it may cover up a heart attack. You may not be able to see a heart attack with this. When we get to talking about the blocks of the different fascicles, we have two kinds. We have a left anterior hemiblock, which we'll see left axis deviation, and then we have a left posterior hemiblock, LPHB, which results in right axis deviation. So if we're looking at these blocks, we needed to figure out our axis deviation, and this will help us determine whether it's an LAHB or an LPHB. LAHB, the left anterior hemiblocks, are more common than LPHB. The LPHB has a dual blood supply. With the hemiblock, one of the fascicles of the left bundle branch, again, we have, I think this is what I just went over. I'm sorry. Let me scroll to the next one. With hemiblocks, the hemiblocks that occur alone are not usually clinically significant, but if we have a bifascular block, the hemiblock that occurs simultaneously with a right bundle branch block, this could be bad, this could be alarming. So these patients are at more risk. So this is the different configurations that you'll see with the hemiblock. So I would like for you to take a peek at that. And then there's a nice algorithm here that you can use to help you determine what type of block this patient has. I'm not going to sit here and go over these next strips with you on the video. I want you to take a peek at them and work through the algorithm. And if you find questions, please let me know. But as you're working these next strips 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10, the answers are in the back of your book. So you can definitely look and compare to see if you're correct or not. But please, if you have questions, let me know.